Hi, and welcome to this special webinar about breast and chest health in the LGBTQ plus community, hosted by the Equitas Health Institute in partnership with WOSU Public Media. Thank you so much for joining us. I'm Cindy Gaylord, Content Director for WOSU TV. I use she pronouns, and I'll be co-hosting our conversation today. Risks, resources, and rights. Three cornerstones of navigating health care for anyone, but in the LGBTQ plus community, what resources do we have? What rights do we have? And what are the risks? Today's topic is breast cancer. LGBTQ plus community members have been shown to be significantly less likely to receive a mammogram due to past negative experiences when seeking medical care. And lesbians, bisexual women, and trans individuals have higher rates of a number of breast cancer risk factors. What can be done? That's what we are here to talk about. Let's bring in our guests. First, my co-host, Julia Applegate from Equitas Health Institute. Happy to see you today.
Thanks for having me. I'm so happy to be here.
This is awesome. And via Zoom, we have two guests. We have Michelle Varas from National LGBT Cancer Network. Good afternoon.
Good afternoon. Thanks for having me.
And we can't hear her in the studio, just letting you know. And we have Lori Gum, a breast cancer survivor. Hello, Lori.
Pleased to be here. Thank you so much for having me.
Awesome. So before we head into our discussion, we have a little housekeeping. We want to hear from you. We will accept questions from you in the audience. Please use the Q&A function on Zoom if you're watching us through the webinar. And if you're watching us on Facebook, put your questions in the comments section. I will be monitoring those questions and bringing them to the table for the panelists to answer. So Julia, where do you want to go first? What do you want to talk about first?
Well, first, I want to say again, thank you for having us here. This is such an important conversation, and it's one that doesn't happen enough. So I will introduce myself first. I work at the Equitas Health Institute. I use she pronouns, and I want to start first by turning over the conversation to Michelle. Michelle's with the LGBT Cancer Network, and I want to just talk with Michelle about what the data is, what the national perspective is on breast and chest cancer in the LGBTQ plus community. So Michelle, will you tell us a little bit about your organization and the prevalence of breast and chest cancer in LGBTQ plus communities?
Sure. Just want to make sure you all can hear me.
We absolutely can.
Great. So as Julia mentioned, my name is Michelle Veras, and I work at the National LGBT Cancer Network. And our organization serves LGBTQ communities across the country. Our mission is really threefold. We educate our communities about our increased risks for cancer. We advocate for cancer survivors and their caregivers in mainstream cancer organizations and in research. And then we do lots of training with healthcare providers and a variety of other entities on how to create safer, more welcoming spaces for our community. So I'll start by saying that a lot of the story around breast cancer and the LGBTQ community is a story of missing data. So we know some things, but we do not know nearly enough. A lot of what we know comes from ecological studies, so observational studies. And from those studies, we know that breast cancer screening rates are lower among lesbian and bisexual women than in the general population. They're also lower among trans individuals. We know that there are higher rates of breast cancer in areas where there is a higher concentration of sexual minority women. And we also know that breast cancer mortality is higher among LGBTQ individuals. What we do lack is surveillance level data. And so unfortunately, that is out of a lack of consistent data collection of sexual orientation and gender identity in healthcare settings.
So when you talk about that data. Can you talk about the ways that it isn't collected? I mean, you mentioned that it's not collected, but I know that there are things like the SEER, like a national registry, that at least the last I looked, they weren't collecting that data. Can you explain a little bit about the ways that the data is excluded?
Sure. A lot of that happens again in healthcare settings. So when folks are visiting their doctors, are they being asked about the sexual orientation and gender identity on intake forms? And then, that information is then fed to cancer registries. And when it isn't there, we don't have it. A lot of the work we do is training and advocating for that data to be collected uniformly at the healthcare level, at the healthcare delivery level.
That makes sense. And have you made progress you mentioned that's part of the policy initiatives of the organization you represent. Are you making progress in that space?
We have made some progress. It is still rather inconsistent. And we have examples of folks around the country that are doing a great job in this area. Equitas is one of those facilities that's doing a great job.
Problem. We're losing our audio there. We've had some vagaries of Zoom today, so we're going to back up and let our technicians work on that. So Julia, tell me a little bit about what's going on at Equitas to help the LGBTQ community find those caregivers, right? That's a big thing, isn't it?
It is, yes. We are less likely to get our screenings on a regular basis. And so, part of that is because we don't know how we'll be treated when we go to the medical provider. And so one of the things that we do is we educate the same way the National LGBT Cancer Network does. We do it in our local context. And in this instance, local means the state of Ohio. So we have a contract from our state health department that funds us to go out and train mammography providers all over the state. We are in our 4th year of that project right now. And so we've trained mammography providers in Cleveland, in Dayton, in Lebanon, Ohio, in Norwalk, Ohio, because as we know, although not everybody recognizes this, LGBTQ folks live everywhere. We aren't just in the urban centers. So we want to make sure that we are training folks. Ideally, anyone who wants to get a mammogram who's LGBTQ plus shouldn't have to go more than 10 or 15 minutes to get a provider that understands them. So that's kind of where we are with doing some of that work. I could keep going on, but how will I know if we're working?
Let's see, can we talk to Michelle? Is she still there?
Am I back?
Yeah,
Yay.
she's back. Yay. Thanks for your patience, Michelle.
Of course. So Julia, to your question around the progress that we've made in terms of data collection, we do have a number of organizations and federally qualified health centers across the country that are doing an amazing job of ensuring that sexual orientation and gender identity data is collected uniformly, that it's not even a thought as to whether or not that information would be collected at those facilities. We do have a long ways to go. We also advocate for data collection on a national level. So in instruments like the BRFIS, which is the largest national health survey, again, we still have states that aren't collecting information on sexual orientation and gender identity among those participants. And so at every opportunity the network gets, we really do advocate for that data collection because, as you know, in health, if we don't have the data, we cannot prove that there's an issue.
Mm-hmm. Yeah, and the proof follows, the money follows the proof, right? So that's the other side of that.
Exactly.
You started to talk about some of the disparities. Can you talk to us about why those disparities exist?
Sure. So we know that about 40% of cancers are tied to health behaviors. And so LGBTQ communities have higher tobacco use rates. We tend to use alcohol at higher rates than the general population. When we think about sexual minority women, one of the factors for breast or chest cancer is delaying childbirth or not having a child. And so that also puts us at an increased risk. But what I really want to stress when we talk about disparities is that individual choices only make up a small portion of our risk factors for cancer, right? So we have to think about the environment in which people are living in. And you mentioned folks delaying screenings because of fear of discrimination. And we know that that's a huge,
Looks like we cut out our audio again. Again, we apologize. We are getting a little bit of technical help here from our behind the scenes folks. I have a question for you, Julia. You talked about folks in the LGBTQ plus community in the rural areas, right? I had a hard time telling my OBGYN that I was gay, right? And I live in Columbus and I've been gay for a long time. So how do you deal with that situation? Is it a education on the caregiver side to create a safe space? Is it an education on our side to stand up a little bit? Where do you see that? What can be helped by that?
That is really a good question, and your question really reflects the approach we take to this project. So we take what we call the two-prong approach, where we're educating both the providers and the community. So, unfortunately, we have to go through the extra steps of educating our community because there's so much shame. At least there has been historically with being a member of the sexual or gender minority community. And especially if you think about in the rural climates, before the internet and before there were easy ways to access representations of oneself, you were kind of alone with your identity as you tried to figure it out. And as someone who's 50, I spent a lot of time in the library, in the darkest corner of the library, reading whatever books I could find. And even that was minimal and no one was talking about health. So I think, what we do is we try to make sure providers understand that they don't need to do really much different scientifically or medically with us, but they need to understand that, we may have apprehension when we are approaching our first appointment. Even if they're waving the rainbow flag, we might not feel comfortable coming out. And so recognizing that many of us carry that with us. And then for our patient population, our community, we talk about making sure people understand what their rights are. That your protected health information, your sexual orientation, gender identity, that's protected health information. And then if a receptionist shouts out the fact that you're a lesbian or you're trans in front of folks in the lobby, they violated your HIPAA rights. And you have a case that you can file against that provider for violating HIPAA rights. So, it runs from talking about rights to talking about things like even just managing your fear, your anxiety when seeking a provider, like talking with our patients and our community about mindfulness techniques and preparing yourself as you go into that first appointment. Hey, if they do misgender me or they use the wrong pronoun, I have every right to leave, or maybe I won't want to leave. Maybe I'll want to use that as a moment where I stop and say, hey, you used the wrong pronoun, use the correct one. And that's a place of empowerment if you're feeling ready for it. So again, it's two-sided and there's so many different angles, but taking that two-prong approach, it's not enough just to train providers. We also, because of historical stigma and discrimination, ongoing homophobia, transphobia, as much as things have changed in, a middle-aged person's lifetime, the climate is not, the situation isn't resolved, right? So it's ongoing work. I think we might have sound now.
Michelle, are you back?
I hope so. Can you hear me?
Well, no, we don't see it. Now, what I am getting feedback from my webinar folks is that they can hear them.
Okay, so.
But we can't.
Maybe we just have Michelle
So,
answer the question.
yeah, well, we'll try to keep up. I do believe our technicians need to do a little bit more behind the scenes. So let's just talk just a few more minutes about this. So what you're saying is that it is a two-pronged approach, that you have folks that feel empowered and maybe can talk about it. You know, my first appointment went so badly. I was 14 years old and just kind of dropped off and left. And this was in 1970 something or other. I'm about 10 years older than you are. So that was a catastrophe. And I certainly didn't want anyone to know that I was gay at that point. And it was a slow process, but a slow process is okay, isn't it?
It can be. I mean,
Okay.
you mentioned that that was when you were age 14.
Right.
You know, depending on what was going on for you in your life, if you were sexually active and contracted an STI, then slow could be dangerous. You might miss a diagnosis of HPV, for example. And I know that there are many lesbians who have HPV. We're here to talk about breast and chest health, but also about cancer generally. If you don't get that diagnosis or caught early, that can turn into cancer, you know, which again is part of why we have higher cancer risks, because we don't get that early detection. So, and it's not just about that interaction with a medical provider. It can be also then that first impression leaves you feeling like, I can't see any medical provider. So, you know, do you delay not only your sexual health screenings, but do you also delay things like your just your annual physical exams? And really with medical care, prevention is key. So anytime that we're proactively getting the care that we need and preventing things that happen in the long run, we're going to have better health outcomes over our lifespan and as a community.
Love it. Love it. Let's see if we can get Michelle back. Michelle, are you there?
I'm here. Can you hear me?
Yes, thank
Great.
you. Thank you
Great.
very much for being patient in our webinar, folks, our attendees. Thank you for your patience. Michelle, we were talking about data and the fact that we need more data to spur the money, right?
That is correct. You know, again, for a long time, there's been very little research on this topic, very little research about why our risk factors for breast cancer and other types of cancer are higher than the general population. We do have a number of folks that are active in this area, and research is coming, but you know, it can't come quickly enough. And I also will take this opportunity to talk about a national survey that our organization has just closed. So in the survey, we recruited about 2,600 participants, all members of the LGBTQ community, to talk about their various experiences with cancer care, cancer screening, survivorship, and the whole cancer care continuum. So we'll have information from that survey to share shortly. But we know anecdotally how different the experiences are. Everything from being welcomed in with your partner, your family of choice, to, you know, we also know that LGBTQ folks tend to be caregivers for folks with cancer at rates higher than the general population. So again, we can't have enough data on this topic.
You know, Michelle, you've set things up perfectly for us to turn to Lori and talk with, meet and Lori. So if Lori can introduce herself. And Lori, can you talk to us a little bit about your experience with breast cancer and what your trajectory is like?
Yeah, I sure can. I use pronouns she, her, hers, by the way. I was a poster child for not getting examinations. As a matter of fact, I am the person in the community you're talking about as a lesbian. I identify as a lesbian. And I had my first mammogram in 2012. And one of the biggest reasons, and I know they were saying 40 and above then, but I had other reproductive issues with having an ovary removed. So they suggested that I start with mammograms earlier. and I didn't go. And so in 2012, my first mammogram, what do you know? At 50 years old, I was diagnosed with DCIS, and that is ductal carcinoma in situ. And although it is a 0 or stage 1 abnormal growth, what it is that it is highly abnormal growth in the ducts, the milk ducts of your breast. It is widespread in mine. It was widespread in the breast and growing very, very rapidly, they ascertained. So they immediately decided that I should have a mastectomy, which I did. That happened very quickly. If I had to do it over again, it happened a little more quickly than I was comfortable with. I didn't really have a chance.
We can't hear Lori in the studio. I'm going to just interrupt Lori for just a second. I know that they can hear her in the webinar. I will, Julia, we're going to talk for just a second until they can fix this for just a second. Lori, I love your narrative there. My wife also had the same type of cancer. We also had that same kind of trajectory as well. We were very lucky in that it was caught early, but how many people, we don't know how many women are like Lori, do we, out there? Because we just don't have the data.
Yeah, that's the problem, right? Is that we don't know. And we do know, like Michelle said, anecdotally. I mean, I can tell you, my gosh, I was at the Ohio Lesbian Festival actually talking about this program, and there were several thousand lesbians from all over the United States and Canada and other countries as well. And the number of people who, when they came to the booth to kind of just interact about the campaign, you know, my sister, my cousin, my wife, my 3 previous partners. I mean, it's just when you're in the lesbian community, it's a known thing. It's we know that our sisters, our community are suffering from breast cancer at extremely high rates. The rest of the world doesn't know because of the data, because we become invisible when we are not asked or given the opportunity to share our sexual orientation or gender identity when we're seeing medical providers.
Yeah, and I think that's the one thing that with our trajectory with my wife's breast cancer, it was absolutely fine. We had no discrimination. We had no awkward moments. Everyone included me and all of that. The one thing that we didn't have, though, was a box to tick to say we are lesbians, that we've had this narrative with reproductive health, that we've gone back from 1998 to now, right? So we didn't have that, and I would love to see that. Lori, are you back? Can we hear you now?
Can you hear me now?
No, we can't hear you now, which is unfortunate. So I'm hoping that our techs can work on that. But that comes to it begs another question, is that the data, to get the data, you have to coordinate with so many healthcare organizations, and they're not just one. You have insurance providers and you have healthcare providers to coordinate that. And that's a difficult thing to get in. It's so layered.
It is. And the good thing is what we've seen happen on the national level and the local level over the last 5 to 8 years is that with the advent of the electronic medical record system, it is much easier to collect this data because it's simply a checkbox that can be turned on in the electronic medical record system. So on the one hand, it's much easier to collect the data because you can simply say, turn on the sexual orientation function, turn on the gender identity function. What's difficult is, there are multiple things that are difficult, but one of the things that's difficult is making sure that people who are in the medical environment are comfortable having conversations with their patients about that data collection. And then also helping people who are of the community understand that sharing that data is important. It isn't asked for invasive reasons. It's asked because it's an important piece of health information. And what we hear is most people who are LGBTQ identified are happy to share that data. We feel seen when we're asked, right. But what can be a problem is when healthcare, either the folks who deliver the healthcare or work in that healthcare environment, and that can run from the front desk person to people taking phone calls or billing, when they mess it up, if a billing person or an intake person says, ex-patient, an assumption is made about their sexual orientation or gender identity, or they're misgendered, that can put that patient right back, 10, 15 years in terms of their health progress, because they feel the weight and the pain of not being seen. It's a heavy thing to sit with, and it's not something that we should have to sit with. When we go to the doctor, we should be thinking about our health, the condition we are there to be seen for, not will I be verbally assaulted or abused because I reveal my sexual orientation or gender identity? Will I be turned away from medical care? Those things happen to people still.
Yeah, and that's unfortunate. Well, let's try again.
Okay.
Lori, are you there?
I am here. Are you there?
Yes, we are here. Again, patience. Thank you very much, our webinar participants, for your patience. Lori, you were telling us about your journey.
Yeah, and so just to add on to what you were talking about, one of the reasons that I didn't go for an examination or a mammogram is because I spent 30 years not having any health insurance, and free mammograms are a relatively new, modern thing that's happening. But back in the day, it cost a lot, and I didn't get them. So anyway, I was diagnosed with this very quickly, had a mastectomy, and the good thing about this was that after that, they took the whole thing. That way I didn't have to do radiation or take medication after that. So I was lucky in a lot of ways, and actually never really saw myself for many years as a cancer survivor because I didn't have to go through any of that. Luckily, I had a mastectomy, and things have been clean since then. I was at the James. I had medical procedure wise was absolutely perfect. They took such good care of me. I don't know during most of the time with my doctor that I ever necessarily told him I was a lesbian. It didn't really come up. And, I didn't have a partner that time to be involved in my care. But I will tell you, and we may want to talk about this a little bit. The only time that I think being a lesbian, and particularly I refer to myself as a masculine identified lesbian, when you're going to have a mastectomy, they demand that you meet with a plastic surgeon to consider reconstruction of the breast, because that begins when the mastectomy begins. And so I was basically saying to her, she's going through all of this. And first of all, it was much more expensive to have reconstruction. Second of all, it took a lot more time off work, and I still didn't have insurance. So luckily, the James works that out with you, but I was looking at all this without insurance, but it didn't bother me. And I was really, really adamant about, I have this great, my body image, my self body image is great. And I said, we were talking about taking one off, and I said, well, you can take both off as far as I'm concerned. And I was sort of joking, but it just didn't bother me. And the look, she was literally taken aback with what I had said. And it wasn't a huge issue, but what would have been nice with this doctor, and it was a female doctor, was to have had some, LGBTQ cultural competency or, cultural humility in sort of understanding gender spectrums and knowing that not all people are going to react the same. Now, when I would have conversations with my cisgender heterosexual female friends, they would say, oh, I would get reconstruction immediately because I'm afraid I wouldn't be attractive to men. And, I didn't have that. I didn't worry about being attractive to women. It just didn't enter my mind. So it was just that subtle kind of awkwardness that I kept telling her it was fine. And really, I don't think she still believed me at the end that I was that okay. There was a sense of, well, you're okay now, but you won't be okay in 2 or 3 years. And anyway, other than that, but it was a very, very interesting situation.
So I believe our webinar folks can still hear, so that's why I let Lori keep going. I absolutely reiterate what you said, Lori. When my wife went and had the consult of, let's talk about reconstruction, my wife looked at me like, what are they talking about? But we had known people that had gone through breast cancer that were cisgender and who were heterosexual. So we kind of knew that it was coming. And I will also sing the praises of the James. I walked in there holding Jules's hand the entire time, and it was fine, right? So they were great. But I do believe that for masculine women, it's a different kind of experience. I mean, my first mammogram was a bit kind of traumatic for me. So is there anything that we can do in the community with each other to kind of walk our way through it, to say, this is going to happen, this is how it works?
I think we can, and I think it's this public, it's the public education campaigns that can really help, and it's talking about it. You know, it's really, you know, for me, I also identify as a masculine woman, and I happen to have small breasts, and I've heard for years, you know, it's harder. It's harder. The first mammogram is going to hurt more because you have small breasts, and so that was my fear. But I also I feel like that sense somewhat of dysmorphia around even having breasts. I as a you know, masculine tomboy, had a lot of anxiety about developing breasts, you know, thinking about having to care for them. I didn't even want them. It's not something that I identified with. I felt a huge sense of relief that they were small. And thank God, sports bras came onto the market when I needed my first bras, because they smashed my breasts even more, and it made me happy. And these are things that, you know, when a medical provider has that kind of background knowledge, then they can hear Lori say, you know, take them both off and understand and laugh along with her. And then the next conversation can be, well, actually, you know, that could be an option. Let's talk about that. Is that something in this moment that you feel is a choice that you'd like to make? And let's explore that. And then Lori or a patient like her can walk away and really feel understood and supported to make a decision that, you know, maybe this is a decision that is not happening consciously. Maybe Lori hadn't been thinking about that, but if that experience prompts a new, you know, exploration of an option, then why shouldn't she be able to do that? I mean, this is body autonomy, and, you know, that is at the root of medical care, at least from my perspective, when we talk about doing care equitably. So I don't want to put words in Lori's mouth, but I know that I've had a number of friends who've had that same experience of the shock on the part of the medical provider, having to advocate for themselves, maybe to make that choice. If they make that choice, having to advocate that they are post-surgically, you know, that the operation is done in such a way that leaves them with a chest that they feel comfortable with. You know what I mean? And that's a different pathway if you're someone who is masculine and is looking for a contoured chest post-surgery, as opposed to a new artificial breast.
Absolutely. Lori, are you back? Can I hear you?
I'm here. Can you hear me?
And for what we were just talking about?
Yeah, it would have been amazing to someone would have offered me the option to have both removed. You know, I mean, you're right, Julia. You know, the conversation was so far from that. But to have that option, and to, there are different ways to reconstruct without, you know, putting in an artificial breast, like you said, a chest that you're happy with. And none of that, you know, was open to me. And I think that would be a radical new way to, you know, care, particularly for, you know, lesbians, and particularly, you know, masculine identified lesbians.
And I have one more question for you. So we were talking about the relationship to our breasts. What is your aftercare now to deal with your remaining breast and your health care now? Do you have a different relationship with that?
You know, it's really odd, and this just goes to show you again. So the side that I had, the mastectomy, you know, that I'm like Julia. I just was indifferent about my breast growing up, a tomboy, and yeah, not wanting them. And you know, it's like the mastectomy side feels right and natural now, and the other side doesn't. And it took me a while to realize that. But, you know, when I look in the mirror and I see this side, or I feel it, it feels right. The breast is still by removing one, it's brought more attention to the other one, and sort of having had, that option to have the other removed, really, I think really would have made a difference. But I go back every year. I'm very good about my mammograms every year, and making sure that I'm taking care of my breast health and my general health. But yeah, it's interesting. Um, had that been an option, it's something to think about.
Lori, we lost you again.
That's all right. I think our web folks can hear, which is fine, but I think I got a lot of lip reading on there. So I think that, the choice needs to be there, and it's not. And I think that we need to do a little bit more of a good job in maybe coming together and saying in a webinar like this, that this is a choice. We need to start demanding those choices. How best to do that? How do we do that?
I mean, it's an entire spectrum. It
Mhm.
is making sure that as we train mammography providers around the state, that the conversation is about the whole process. It's about when someone calls and makes an appointment, what do their intake forms look like? What does the lobby look like? Do you have things in your lobby that reflect my life experience? Rainbow pins and buttons and stickers and magazines. Do I feel seen? And then at diagnosis, if there's a diagnosis, it's then when you see that oncologist, does the oncologist have that awareness? Talking with patients on the front end before going into surgery in a way that is open-ended. Here's what we found out. Here's what we're going to need to do. Let's explore a range of options. And I think that you would probably find many, many people, because, there are men who have breast cancer as well, who would be really happy to hear a range of options that is a total range, without assumptions being made. I had some options presented to me when I had to have a plastic surgery on my nose that was nothing to do with my sexual orientation. And the plastic surgeon was like, well, while we're fixing your broken nose, we could shave a little here and cut a little there. And I was so offended. I was like, don't your beauty standards don't belong in this conversation right now. And I think that that's part of what happens with a lot of medical care, is that people make assumptions about standards of beauty, body standards, and then try to impose those on patients instead of saying to patients, here is the entire range of options without value and judgment. What would you like to explore? And then have an open conversation, and then get the patient what they're asking for.
Right.
And if that involves, hey, we didn't, medically you only need to remove one breast. I understand you want to remove two. Let's talk to the insurance company. Let's figure out what coding we need to do. Let's look at patient assistance programs. Let's do the whole thing. And so that when you leave our care, you leave with having received knowledge about all of your options and getting the care that makes you feel whole.
Absolutely. And I think a lot of that is just not assuming. You said
Mhm.
open-ended questions. How are you feel like you're going through this process? What is working in your body? What are your thoughts about your gender, your sexuality, your body? Boy, if we could have that in just the entire population as a whole, that would be quite awesome. Lori, are you back? Can we hear you again?
I hope so.
There you are.
All right.
So, Julia, where would you like to go from here?
Well, Lori, I've spent a lot of time talking because of the audio problems, but you shared that this is really one of the first times you're talking publicly about this experience and your recovery. So why the delay? And you've talked a little bit about some things already that you might have had to think about with disclosure, but can you talk to us about that?
Sure. And, I have been an out lesbian since 1979. So, I've been long in the community. You know what it was? I tend to be, it was not purposeful. I tend to be very private with things like illness and health, just things like that naturally. But I will tell you honestly, with the relationship I have with my breast, I just really did not want any public conversation being about my breasts. It had nothing to do with cancer. I was not ashamed to have cancer. I was not ashamed to have a mastectomy. I just didn't want, and once you have a surgery, everyone wants to know how you are. I mean, they're caring and they're being compassionate, but I just didn't want to have conversations about my breast. And it really came down to that.
Mhm. And, for a medical professional to understand that, just that alone, I think is something that takes time, and it takes conversation, it takes training and education, because it sounds for you like this wasn't a sexual orientation thing, that maybe it has something to do with your gender identity. I don't know, but how can we as a community of people who do this work help our providers understand what's necessary to make you feel comfortable?
Yeah, and I think it is very much sharing stories like this, and not only have I generally not talked about sort of my journey with breast cancer, but certainly not about those feelings that I had about my breasts and using my breast, those very personal things. And I'm completely comfortable with that now, because having been, in the community for years and years and working as an activist for years and years, I realize how important it is to tell our stories. And I think it's telling these stories, and even with the medical personnel, learning these stories and hearing this could do a lot to change the sort of landscape, the treatment of breast cancer landscape.
So we've lost our audio just in the studio, but that's all right. We know that our webinar folks can listen, and that's fine. I've got a couple of questions. Well, actually some observations from some of our participants. This is from Elizabeth. The breast cancer subculture is so gender laden, and it is also framed in a heterosexual lens. Pink ribbons, women's health, that doesn't really affirm trans guys, absolutely. And the focus on cosmetics and appearance to either pass as not a survivor or to satisfy society's views of what women should look like. Beyond educating providers, we need structural changes in our healthcare system that allow affirming care. I think that sums up what we've been talking about the last few minutes very, very well. Absolutely. I totally think that that's a really great point, don't you?
Absolutely. And, we talk about pink washing.
Mm.
Everything in May starts to turn pink. Razors, baseball bats, and that's fantastic in some ways, but it doesn't capture the experience of the totality of people who have this diagnosis. And, one of the things that we did as an organization was we've created all of our promotional materials are green or brown or a rainbow, because we want our patients to see themselves in the materials that we create. And that doesn't mean that, you can say LGBTQ people like green better than pink, but pink is so associated with not just femininity, but a certain kind of femininity, and with often with a heteronormative femininity and a very hyper femininity, and a very polished and beauty, rules femininity. So that's kind of some of the stuff that we try to work against, to bring attention to that issue.
I get it. Sue has another comment. If insurance will pay for reconstruction, it seems like they should pay for removal of the non-cancerous breast. The goal should be symmetry in a way that works for the person involved. Your comment.
I absolutely agree with that. I don't have enough experience with this personally to know if insurance will do that. I do have a friend who was not given the option of, it's just tragic. I don't even know how to talk about it without it sounding awful, because it just is. But after her surgical experience with removal of the breast, they didn't reconstruct her chest in a way that was affirming. She was left with, because she said, I don't want a reconstruction. And her surgical scars weren't, reconstruction of them in a way that was affirming for her was not an option and was not paid for. And so, interestingly, when you think about, if you know lesbian culture at all, the Amazons, the story is that they removed a breast so they could fire their arrows and defend themselves. And so, we culturally will take our experiences and reclaim them. And I think in her case that she has pride in her body. And that is a powerful thing, but that is not something that she chose. And we should be given the choice to have our bodies post-surgery look the way we want them to look.
Absolutely. Just want to remind our webinar guests and people on Facebook, please write in the comments anything, or the Q&A, any comments or questions that you might have. I'll bring them to the table. Lori, are you still there?
I'm here.
Oh, fantastic. And Julia, where would you like to go now?
Well, I know one of the things we wanted to talk about, and this, I think I'll point to Michelle and then Lori. When we talk about how questions of race and ethnicity intersect with sexual orientation and gender identity, Michelle, can you start by kind of talking us through how some of these things might be different if for a person who's experiencing cancer that is also BIPOC?
Sure. I think, all of the things that we've talked about in terms of lower screening rates, financial concerns when seeking care, concerns about discrimination from providers are all, significant challenges for communities of color. So when you're thinking about living at the intersection of being an LGBTQ person and also being a person of color, these things are really just compounded. And a lot of the conversation earlier, Julia, when you were talking about providers just, not making assumptions, along with that, I would just like to stress how important it is that providers really think about the whole person that is coming in for care, right? Like, I live at the intersection of many identities, and these identities are all impacting my experience with cancer diagnosis, whether it's breast cancer or any other kind of cancer. So, again, data here is lacking, but we do know that the experiences of BIPOC are even more challenging in LGBTQ communities.
Thank you, Michelle. And I think, to add to that, the shortage of providers who are BIPOC, and for folks who are not current with their technology, Black, Indigenous, and people of color communities. Many marginalized people want to see providers who look like them. So, for a person of color to find then a provider who is of color and then also a member of the queer community, we talk about a unicorn, right? We can't find people who are like us for our medical care. So I think there's literature that shows that too, right? That we do better as patients when we have providers who are like us.
Right. I mean, again, working at a national organization, and I can name less than a handful of oncologists that I can think of that are BIPOC and members of the queer community. So it is such a challenge finding those folks, but we know that we do better when we're seen by people that identify the way that we do.
Mm-hmm. Lori, do you have thoughts when it comes to thinking about this topic intersectionally?
Yeah, I mean, it just adds, so many layers of difficulty. Yeah, like I said, just, the issues that I had, if you have all these other issues of sort of race on top of it, I mean, it's just such a difficult, like you're saying, difficult to find someone, that shared experience. Like you want your medical professional to have your shared experience. And that's just, like you said, it's difficult to find. And it's just something we have to keep continuing to try and do is, attract our community into those professions. That's another way to do this. And Julia, I did want to just add, when you were saying about your friends being sewed up. So when I was there was sort of, I opted against reconstruction. It's just a gash. Like they just did it and sewed it up. Like there was no sense of any kind of, like you said, it didn't even occur to me that there should have been something different. It was either a new breast or we'll just cut it off and stitch up. And, that was acceptable to me even then. Now, when I look back and with you talking about that, I sort of remembered that. And another reason I didn't want to talk about it too, is I didn't want to be around that pink thing. I mean, that pink thing was just such a turnoff, such a turnoff. I didn't want to put on a pink, robe. I didn't want to put on pink slippers. I didn't want anything, pink to do with it. And that's, it really does have an effect. You're right.
Mhm. Yeah, the pink is powerful. And I think that, again, for people who are queer or different in terms of their gender identity and expression, pink it implies so much that
Yep.
can feel so alienating, to the point of, not wanting to get the medical care, not wanting to go to the race for the care, not, all these things, right? And we who have that feeling, and I am sure there are heterosexual and cisgender women who also recoil from the pink. We should be able to be seen and affirmed in those spaces, and not have our conversations about that be something that is seen as an affront by organizations that are so much on the pink bandwagon. You know what I mean? Like, I feel like if we could get to the place where some of these national organizations could just hear and see that we could still have pink for the people who like that, but recognize that there are other experiences as well. So we're getting kind of near the end here, and we probably have some more questions in the chat. Michelle, kind of parting thoughts, what would you want to share for before we go into any other questions?
I think a lot of what we've talked about today that I really kind of want to just reiterate is that there are individual choices that we make around our health that do increase our cancer risk, but really this doesn't exist outside of the context in which we live. So again, really stressing that it is this combination of individual behaviors along with a history of discrimination, targeting by big tobacco, lack of access to providers that understand us and that are welcoming. You really can't separate the two. And so I really just want to, have folks walk away with that understanding that this really is just such a multi-layered issue.
Mm-hmm. I'm so glad you brought that up. I know we started talking about it earlier. I'm somebody who have had some of the classic kinds of disparities that fit our lesbian data. And I never started smoking, but I did drink a lot in my 20s and 30s. And when I reflect on that, I was drinking because my cohort was drinking. We were drinking because that's where we hung out.
Exactly.
I was drinking because I had so much internalized shame for my identity that's the only way I could be sexually active with someone. Mm-hmm. It was a product of the culture that I lived in, the pressure, the stigmatization, the homophobia, all of that. And, had I not had a grandmother who suffered from emphysema, I probably would have smoked too, to take the stress away, because smoking takes stress away. Right. And again, like, these are why so many times it's so common that we're making those unhealthy choices, because those are coping mechanisms for the way that the world has hated us.
Exactly. I think that you put that very eloquently. I think that, to counterbalance that, I'd just like to talk about how important community is, right? So, traditionally, we've picked up smoking because that was what was happening outside of lesbian bars and, drinking and all of that. But I also think when we're having conversations about cancer and cancer screening, how important it is to say to our friends, hey, have you scheduled that mammogram? Let's go together. So again, this idea of reclaiming, I really, think that that's so important for our community to take advantage of those community connections and really hold ourselves accountable and take care of each other.
Yeah, that's such an important point. I'm going to pass it to Lori here in just a second. I want to say that we locally, I know we have people listening from all over the place, which is an incredible benefit of Zoom. But for folks who are in Columbus and Central Ohio, we are doing a public screening, a breast cancer screening event in partnership with the James Cancer Center at Ohio State. They'll bring their mobile unit down to our clinical site in the King Lincoln District here in Columbus on May 24th. We have 12 slots that we need to fill for that, that event to happen. And we're doing that in a way that we hope will feel community building. We've hired a lesbian performance troupe to do some drumming. We've got a group of trans folks who are coming together for that event, even if they don't need screenings yet, but just for the public education. We've got some raffle prizes that are chest binders for folks who might have breasts that they want to bind. We have, we've chosen things that our community will, we think, like, so we're not doing raffle prizes that are just a random water bottle. So, and again, in the way of trying to be culturally humble. So we hope that that event will attract a good audience. So I think one of my colleagues that's sitting back in the office will post information about how to sign up for those mammograms for anyone who might want to come. Lori, what kind of thoughts do you want to leave our audience with? And we will take time to go to 1:15 with questions, but Lori, what do you want to kind of close out with?
Well, first of all, your kind of mammograms are my kind of mammograms. That's just fantastic. I would have been going to mammograms all the time if there were drums and raffles and gifts. I mean, that's fantastic. I will just sort of leave you all with this that is listening. It is important. Like I said, the first mammogram I got at 50, I ended up, having DCIS, and it's important. Go with a friend. That's a great solution. And when you get a mammogram, mention to your friends that you went and got one, so that it is as Michelle said, let them know that you're doing this and that they should do this too. And tell your story. Tell your story. We know as a queer community the power of that, and tell your story. And, if you're scared to go, tell someone you're scared to go. Be honest about that, and help yourself find ways to make, the anxiety less, and just make it, a better experience. I just really want to tell you, get those regular mammograms.
Thank you, Lori.
We do have just a comment here from Angie. Can share what the specific breast chest health screening guides are before you go. I'm not quite sure what that means, but because I think there's a little bit of a typo here. But I think that, the knowing what you're up against, right, is it has a lot of power, right, to be able to go, to say what is going to happen here. My 14-year-old self would have loved that, by the way.
Yeah.
But it would I think, to know what's happening and what are the guidelines and what are we looking for and what could be some of the outcomes is something that we need to take on, not just as as individuals, but as a community, to say, let's start talking about this, right?
Mm-hmm. Yeah, for sure. And, there are guidelines specific to our population. We'll be talking about that next month with one of our guests. There are new guidelines coming out by the American Radiological Society that are specific to the trans community. I can hit on a kind of high note. I'm going to refer to my book here to make sure that I don't get anything wrong, because this guide that we've created, it is, I don't know, 14 or 15 pages, all about the entire journey of breast and chest health in our population. So for trans men and non-binary people who have breast tissue. So this would be individuals who have not had a reconstructive top surgery. I'm sorry, I'm reading this wrong. If they've had a chest reconstruction top surgery at age 40, you should talk to your nurse practitioner or your doctor every year when you have your physical about your health, your breast and chest health. And it's advisable to do a breast or chest health self-exam every month. So we have some instructions in our guide about how to do that. And we're happy to make these guides available. If anybody would like one, just drop your name in the chat and we'll mail them out to you. For folks who are trans or non-binary who have had breast reduction top surgery beginning at age 40, you should have a mammogram every year. So if you've had, I think we might have a typo here. If you have not had top surgery and you're a trans man, you still need to have your mammogram as you would normally, because the issue is that you still have breasts. So even if you don't identify with those breasts, if they are still on your body, you need to have that mammogram regardless. For trans women, if they've been on hormone therapy for 5+ years and they're over age 40, I believe, they should also have that mammogram. And they should be talking to their physician about this in an ongoing way, because again, in our community, we have people who have breast tissue that they've had with them for 30 years, and then maybe they take that breast tissue away, or we have people who are new to having breast tissue because they've started hormone therapy. So I would point you to our webpage, and you can download this directory rather than me trying to read it.
And what's the webpage? Equitas?
It is equitashealthinstitute.com. And there is this directory is downloadable as a PDF, and all of the information that's in the directory can be read there. So, and maybe Michelle, do you have additional thoughts, things I might have not covered?
No, not in terms of recommendations. I think you've covered it.
Okay, thank you.
That is awesome. My comment here, because I feel like I've known Lori, because you know, I'm a child of the 70s as well, that I think that for older lesbians, you know, I feel like it has been a bit tougher because, you know, we got busy. We got careers, we got family. Some of us got married in Toronto, 2005. And maybe we come in and out of the culture a little bit differently, right? Than maybe we did when we were in 23, 24, 25. So now we are the population that does need to keep up with their health and their chest health. Lori, do you have any recommendations for other women like us that that need to take care of themselves?
Well, you know, I would say this sounds crazy, but find a pal, like, you know, find your other, you know, tomboy pal or, you know, masculine identified lesbian, find a pal, you know, really that someone that you can talk with about, and just to talk it out, just to say it, to, you know, get it out of your head. Find a pal, find a breast pal. That's what I'll say.
Find a breast pal.
A
But it's
breast
hard,
pal.
don't you think, Lori? I mean, sometimes we're talking about very sensitive things, and I know
Yes.
that we all kind of decided we're going to talk about this today, but you don't just bring up your chest in a conversation, right?
No, I'm just starting to talk about it now. You know, I haven't talked about it for, you know, 10 years now. But I have found, you know, women along the way that I could confide in. And it isn't easy, but again, trying to go it alone and figure it out all alone is not a great place to be. And again, reaching out to like Equitas or counseling or finding some counseling that can help you with this, especially if you have high anxiety, you know, to the point where you aren't getting these examinations. You know, seek help, seek a community, and seek others that can help you through this, as opposed to just not doing it.
Absolutely. And I think Equitas has been that much needed stopgap in the community to start the journey, because it is a journey, don't you think?
It is. I think, you know, we have to remember that we're whole beings. And, you know, as LGBTQ folks, many of us have been reduced to our sexual behaviors. And so when people, if they were thinking about our health, they're thinking about our sexual health. And oftentimes that meant, you know, thinking about HIV, and which consequently meant thinking about men. And the way that America is, that meant thinking about white men. So when we now have an organization like Equitas Health and other FQHCs that do this work across the country, you know, making sure that those medical providers also, because they grew up in many of them in the same world that we did, that we have to think about health across the lifespan, and we have to recognize that LGBTQ folks, you know, it's cradle to grave, right? You know, we have mental health issues, we have diabetes, we break our elbows and have to go see an orthopedic surgeon. You know what I mean? So we are whole beings. We have many different kinds of health concerns. We will have them across the lifespan, and we need providers who can not just understand us, but who want to take care of us and who will advocate for us. And I am hopeful because I see them. They're there. You know, there are more and more providers. There have been providers all along, but there were, you know, if you were, as we are, older lesbians, you know, you knew the 3 people in town. You know, you could rattle them off. Beth Trainin, Shelley Blackburn, you know, we knew who to go to. Well, there are more now. There are more people who identify as LGBTQ becoming providers, and there are more allies and accomplices who are recognizing that our experiences have been unjust. And they're saying, you know, hey, maybe I am heterosexual and cisgender, but I want to take care of you because you don't deserve what has happened to you. And I think having these dialogues and conversations are so important, so that, I don't know, join the fight to make healthcare inclusive and affirming for human beings in our complexity, you know, our race, our skin, our all of that stuff. Like, I don't know, I can't say enough that I think that is what will decrease health disparities in human beings, is that culturally aware, sensitive, affirming, empowering medical care.
Absolutely. Michelle, one last question for you.
Sure.
Self-reporting, that's part of this whole formula, right? I mean, seeking out a breast buddy, I love that, Lori. Seeking out a breast buddy is awesome, but also self-reporting. So how do you do that if you are, let's say me, and I go to, you know, my doctor? Is there a box there that I can tick? I know that we talked about electronic, you know, chart information. What else is available to me so I can be counted?
So I think that's a wonderful question. And I, you know, just kind of piggybacking on what Julia was saying, I think that if you go to your doctor and you don't see a place that they're asking for your gender identity and sexual orientation, ask them why not. And if you are working in that facility, if you are front desk staff and you're looking at your forms and realizing that your office is not asking these questions, we need LGBTQ health champions. So please be that champion, bring that up. Why aren't we asking this information of our patients? You know, as Julia said, the majority of us are comfortable disclosing when asked. We want to be asked, we want to be seen. So even if there isn't necessarily a box, I would ask your provider why there isn't one and what can be done about it.
That's a great answer. I think that's awesome. I love that we are in a point in our trajectory as a community that we can ask that question, because I think, Lori, you and I, you know, as the elders at the table, probably in, you know, in the 70s, 80s, even 90s, that would have been really difficult. Lori, do you feel comfortable even doing that now?
Well, I will tell you, yeah, it's getting more comfortable. It's getting more comfortable. But, you know, I lived through the years. I've known Julia for many years, and we used to sit and talk about, wouldn't it be great if we had, you know, this health center for the queer community? I mean, Equitas is a dream come true for the Columbus queer community. I was an ACA certified application counselor in, you know, 2013, getting people, you know, on the marketplace, some getting insurance for the first time. But then we talk, well, we got them insurance, but now there's no culturally competent, you know, healthcare. So I just applaud, what Julia does and Equitas. I think the world of you all, and that makes me feel better about things. I have somewhere to go. If I'm not comfortable for some reason with the doctor I have now or a procedure, I have somewhere to go now that's going to understand it. And that's so comforting, even if you don't have to use it.
I think you make a good point, Lori. And I think the other thing that's happened in part by having an LGBTQ centered medical home is that we know we can't take care of everybody. Yep. And the community knows we can't take care of everybody. And there are other providers in town that are feeling, I think, more affirmed to wave their flags and publicly promote that they serve us with humility. And we've developed referral relationships because, we will fall down and hurt ourselves, or we will become pregnant and need to go to the doctor for pregnancy care. And so having referral systems in place with surgeons and other kinds of medical providers is, I think that you're seeing a much more developed web than when, 6 or 8 years ago, you were enrolling people in the ACA. We didn't, we were just trying to find a primary care physician. There was no option if you had cancer, but now there are. Now we have oncologists that we list in our provider directory, and we're taking more all the time because more and more people are saying, hey, I recognize this disparity. I want to be part of the solution to the problem, so that gives me a lot of hope.
So yeah, and as an elder here, we never thought we would see marriage equality, but boy, we never thought we would see a queer health center like that. That was even beyond dreaming about marriage equality. So it feels good being queer in 2021. It really does.
Mm-hmm. So Julia, if a provider wanted to be part of Equitas, how does the provider get in touch with you and get within the system?
So we have a health directory that we produce. That's also linked on our webpage, equitashealthinstitute.com. There's a process. We ask 5 questions of providers, and it's all self-report. We ask them, are their forms and paperwork inclusive? Do they have trans-specific services? Do they ask open-ended questions like that enable you to reveal your partnership status or relationship status? I can't remember what the others are, but as long as a provider can answer yes to at least one question, they can be listed in our directory. And then we have a code that indicates how many of the 5 criteria they meet. And so that directory is available on our website. And it's just as simple as completing a survey.
That's awesome. Michelle, when a provider would like to report out some of the numbers, let's say that they've decided to self-report or create boxes to tick when we're LGBTQ+, is there a national database that they should be trying to hook into so they can report out?
So when we're talking specifically about cancer, yes, there are national cancer registries, or Julia mentioned the SEER registry. Just general health, I do not believe that there is.
Okay.
No, not to my knowledge. But again, this is part of the policy and advocacy, so we need to continue to do the policy and advocacy so that we can have databases like this. We're not, you can pull data in the United States and know exactly, well, maybe not exactly, but very good numbers about how many people of color there are and how many, by age, census data. But we don't, we are not included in the census, not in a way that is accurately collecting our numbers. So in all of those ways, we just continue to be invisible.
Right. So there's advocacy on many levels, individual level, kind of the medium, the relationship with the physician and or the healthcare institute of some sort. And then there's advocacy on a very large level, which is the data. And remind viewers, data equals money. How does that work?
Well, if your science is part of it, right? Like we in many ways, we hold science as our way to prove something, right? And so if we scientifically prove that there's a disparity, then we can justify why we want money to fix that disparity. If we can't prove with science that there is a disparity, then funders will say, well, there's no problem. Doesn't matter how many people you talk to or how many individuals tell their story, until you can prove it, we're not going to put out money to solve the problem. So it's, there are funders that will fund this work. I believe, correct me if I'm wrong, Michelle, I think it's the CDC funds the National LGBT Cancer Network. So there are sources, but they're not enough for the breadth of the problem.
And before we go, one more plug for your event that's coming up in May for mammograms. Where are we going? What are we doing?
So you're going to the King Lincoln Medical Center, the Equitas Health King Lincoln Medical Center on Long Street, across from the historic what's it called? Lincoln Theater.
Mm-hmm.
And there will be a bus there by the James Cancer Center where you can get your screening. All of those mammography techs have been trained to serve you with cultural humility. We're there from 9 a.m. to 1 p.m. You must register in advance if you want a screening. You need to do that by May 10th. We will have food and drinks and drummers and raffle prizes. And even if you don't need that screening, just come join us and be in community. Grab your breast buddy. I wrote that down, Lori. I'm going to use that. Grab your breast buddy and come down. And if you can't join us in person, we'll post some pictures on our Facebook feed. So
that's awesome. And where can people register? There's a phone number and on the website as well?
There is a flyer circulating, and I hope one of my colleagues will post that.
I have some information here. Can I give the number out?
Yes, please.
Call 614-293-4455. 614-293-4455. That's the number to call to register. And it is also on the EquitasHealthInstitute.com. Is that right?
Absolutely. Yes.
That's all right. That is awesome. Well, it's about all the time that we have today. I am thrilled to be with so many amazing women here. This is such an affirming afternoon. We could talk all day, especially Lori and I. So this has been a fantastic afternoon. So Michelle Veras from the National LGBT Cancer Network, thank you very much for being here.
Thanks for having me.
And Lori Gum from Columbus, I hope to meet you in person very soon. Thank you for being here.
Thank you. My pleasure.
And Julia Applegate from Equitas Health Institute. Thank you.
Thank you so much.
Join us for our next webinar. We are doing this again Thursday, May 13th at noon as we talk about breast chest screening recommendations for transgender patients. You don't want to miss that. Thank you all for joining us and working through all of our technical issues. We really appreciate it. Have a great afternoon.
Bye, everyone.
Bye, everyone.